look, I'm getting these really funny heartbeats. Oh, that's anxiety.
Other aspects of lifestyle which may be relevant.
Be patient with yourself and just build up gradually.
So I just needed to have them work with me.
There's a whole bunch of cardiomyopathies.
Benefits of doing genetic testing.
Take their own heart monitor. There's better types of fat.
Try and find a cure for inherited heart muscle diseases.
I'm just going to preface my talk by saying that there are moments when things change, and they're often quite unpredictable when they change. I've been coming to this meeting for a long time. And there have been moments during that sort of experience when there have been new developments and so on. But I actually think we've reached a tipping point in a number of really key areas. One of those is one of the things I'm going to be talking about today, which is about therapeutics. But those of you who were in the sessions that I was in, we had some very interesting, broader discussions about what we all want from healthcare. And for me, that's been the thing I'm going to take away from this meeting, because as a medical charities, we've been focusing on disease, education, promoting best practice, supporting the existing system through nurses and so on. And that will continue. But if we want to make it less rubbish, because we know that it is rubbish out there, we've got to do something quite radical. So that, for me, is the thing I've taken away from this meeting. So it's down to you guys to help. But let's get back to something a bit more conventional. And I was asked to talk about New Horizons and Back to the Future. Okay, so I've been in cardiomyopathy land for quite a while. Does anybody in the room know who these two people are? Probably do. Not many people will remember. This is Celia Oakley. This is John Goodwin. Back to the 1950s, 1960s. How do we think about heart muscle disease? We describe what we see. It's a thick heart. It's a dilated heart. That was 1950s, 1960s. And in that sense, not a great deal has changed. So we still talk about cardiomyopathies by what we see on echo, MRI. Thick hearts, dilated hearts. You've heard a lot, I suspect, at this meeting about the recent European Society of Cardiology Guidelines, published this year, chaired by Juan Kasky, who's also spoken at this meeting, where we've maintained these terms. We've introduced a new one, the slightly clunky, non-dilated left ventricular cardiomyopathy. These terms still have meaning and value, so we can start to characterize patients by what we see on an echo and MRI. And we do tailor our management to this. So we think about the mechanism of symptoms. We think about family screening and determining and explaining genetic risk to relatives. We try to identify individuals who are at high risk of disease-related complications, which means heart failure, stroke, or sudden cardiac death, and try to mitigate or prevent those. And where appropriate, as you've heard a lot about pregnancy, but other aspects of lifestyle which may be relevant to living with cardiomyopathy. So there's a lot of things we do based around this paradigm of what does the heart look like. In some instances, this can be transformative. In the sessions around dilated cardiomyopathy, we identified some well-known information sources which are wrong. There's still this legend that everybody's going to die from dilated cardiomyopathy before the end of the week. But actually, the impact of modern therapy, ACE inhibitors, the sartans, Entresto, spironolactone, pacemakers, defibrillators, has been dramatic in dilated cardiomyopathy. The outlook is so much better than it was 10, 20, 30 years ago. And what we can do in HCM, DCM restrictive isn't just confined to the drugs. We have ways of trying to prevent atrial fibrillation. We can prevent stroke. We can treat ventricular arrhythmias. We can even treat valve disease, which is sometimes a consequence of cardiomyopathy by surgery, but also by clipping valves on a catheter. This slide actually shows you the impact in dilated cardiomyopathy. So these are survival curves. So this is sort of where this 50% of people dead in 2 years comes from. But that's the 1970s, 80s, thousands, more contemporary. The curves are flattening. And this is the use of good medical therapy. So why do we need something else? What's next? Do we need something else? I tried to make this point in I think the first talk I gave, is that the way in which we do cardiology is that we see big pictures. So we have someone who presents with breathlessness, they have heart failure, we measure a number, this magical ejection fraction that probably most of you are familiar with, and according to that number we give good medical therapy, and on average most people do very well. But within the noise, within those stories, lie other stories where the current standard of care is not what we would like it to be. So if you take all comers with dilated cardiomyopathy and just look at those who have a mutation, a genetic mutation, and those who don't, then the rate of ventricular arrhythmia, sudden death, is much higher if you're carrying a bad gene. If you actually look at the genes, then there are two genes which are problematic. One is lamin, and another one of what we call desmosomal genes, desmoplakin, desmogliin. That was in this series, there are others. So you're starting to see this separation out of different stories according to the genetics. I used this example in the other talk that I gave. Laminopathy, it's about 8% of people with dilated cardiomyopathy. Oh. Should I take a message? Where if you have laminopathy, and if you have anything, if you have an abnormal echo, if you have an abnormal ECG, if you have an abnormal Holter monitor, your survival immediately starts to tail off because of sudden death, and the ejection fraction can be normal or near normal. Now this recognition is already being fed into guidelines. So back to the 2023 guidelines. If you look at the purple boxes here, this is what we've been doing for a couple of decades maybe. So if you've had a cardiac arrest, you put in a defibrillator. If you've not had a cardiac arrest but you've got a really bad pump, less than 35%, you consider a defibrillator. What we've said is now you should start thinking about genetics. And if you've got a high-risk gene, then again you might start to think about putting in a defibrillator. So what this is the beginning of is this notion of personalised medicine. Yes, you've got dilated cardiomyopathy. We've measured your ejection fraction. But what we're going to do is determined by the underlying cause of your disease. That's dilated cardiomyopathy. What about hypertrophic cardiomyopathy? Well, quite rightly, we spend an awful lot of our time trying to identify individuals who are at high risk of dying suddenly. You know, you've heard about Google moments today. You know, you get a diagnosis of hypertrophic cardiomyopathy, you go home, you put it into a search engine, and what you screams back at you is sudden cardiac death. That applies to a minority of individuals with this disease. And we're pretty good, I would argue, at identifying the high-risk patient and protecting them with a defibrillator. What we're not good at is changing this trajectory, which is the progressive occurrence of heart failure. It's always sort of, I've always found it curious that when we think about hypertrophic cardiomyopathy, we think about hypertrophic cardiomyopathy and dilated cardiomyopathy and sort of different problems. One sudden death, one heart failure. They're the same. It's just in hypertrophic cardiomyopathy, it may take 10, 20 or 30 years before you reach that point. And at the moment, we have no medications or any interventions that we knowingly use which prevent that from happening. So this is a significant unmet need. The other thing, of course, about living with cardiomyopathy is that people live with it. They live with it. And you adapt your life to it. but it's still a bit rubbish. Because you know you're going to get breathless if you go up that hill or that flight of stairs. You know you have frequent palpitation, fatigue. You know if you kick a ball around with your kids, the next day you're going to be completely knackered. That's living with. And there's an increasing focus now on what can we do to help people live with, to alleviate these things, because most trials in cardiovascular medicine are about making people live longer, which is fine and is important, but they're not necessarily about making people feel better. Now, I said, in my little speech at the beginning, that times are changing. Here's some examples of companies who are now in the dilated cardiomyopathy world. This slide represents billions of dollars of investment. And I could do the same for hypertrophic cardiomyopathy or indeed ARVC. The pharma industry is way ahead of us in identifying this huge unmet need in cardiomyopathy. And this is why I think we're on the verge of something really exciting. Wouldn't it be interesting if, rather than just treating the symptoms, we could treat the underlying cause of these conditions? Now, the poster child for this, the vanguard, which proves the principle that this is possible, is this condition called cardiac amyloidosis, which is probably not relevant to the majority of people in this condition, in this room. It's actually quite common. Cardiac amyloidosis is a family of diseases where you get proteins, abnormal proteins laid down inside the heart. It can occur as an inherited disease. I was reflecting on the question earlier about, are there groups of people who are prone to cardiomyopathy in our society? One of the commonest, if not the commonest genetic condition causing cardiomyopathy affects people of black West African descent, which causes this condition. It's 3 to 4% of people with that ancestry carry a genetic variant which predisposes them to amyloidosis. The good news is that we understand the biology, at least of the acquired form. It's caused by this protein which is released from the liver called transthyretin. And for reasons that we don't understand, this protein has a tendency to break up. And then the bits circulate around the body and then deposit within tissues, and in particular, within the heart. So understanding that biology, we've now got drugs which can stabilize that protein, stop it breaking up, stop it depositing as amyloid, what we call stabilizers, TTR stabilizers. And we now have a randomized trial called the Tract trial, showing that if you give this drug, you can reduce the mortality by about a third. And this is a population that don't normally get into studies because the median age is 75. Even more importantly than making you live a bit longer is that you stop the progressive decline in exercise intolerance and symptoms. So you stabilize the disease. Now, it's not the only drug in town. There are others in town. This one is recently presented at the European Society of Cardiology meeting. Coromidis does the same thing. Something really interesting, again, amyloid as this poster child. So you've got all this protein in the heart. We can stop it depositing with these drugs. Can we make it go away? Well, here's the first hint that you might be able to make it go away by giving an antibody which binds to the protein, and then you use the body's own immune system to clear it. And trials on this are now underway. Is that word cure? Could this be a cure for this disease? So that's amyloidosis. What about the stuff which is perhaps more relevant to this audience? So this is our old friend hypertrophic cardiomyopathy, big thick heart. We've understood since the late 1980s the genetic basis of this condition. It's caused by mutations in genes which make up the cardiac contractile apparatus of the heart, what we call the sarcomere. Now, until very recently, that didn't translate into very much in terms of treatment. So we do have ways of treating this. We can treat breathlessness, we can treat obstruction with surgery, we can treat atrial fibrillation. But what I want to do is just focus on two elements where there's change. One is obstruction, and the second, potentially progressive heart failure. So this is something which a lot of you will be familiar with, this phenomenon of outflow tract obstruction, which affects at least a quarter, probably a lot more people with hypertrophic cardiomyopathy. What you see here is the ventricle. This is the top chamber of the atrium. Here's that valve. Look, if you look really carefully, to see as the valve shuts, it bends forwards like that, and it touches the muscle and gets in the way of blood as it goes out of the heart. And this can cause chest pain and breathlessness and blackouts. Again, taken from the ESC guideline, the conventional way of dealing with that are beta blockers. If they don't work, or if people can't take them, we would give calcium antagonists, what drug verapamil, diazepam, and then if that doesn't work, we add in a drug called diazepam. Is anybody in the room on diazepam? Yeah, you're a dying breed, because the drug is almost unavailable now. You can't get it. No, it's almost gone now. It's a filthy drug, though, isn't it? Dry mouth, dry eyes, can't pee, can't poo, yeah, all that stuff. Yeah. So I didn't mean to shine a light on you about that. Look in the yellow box here. Suddenly a new drug has appeared, mavacamten. Now, this is an example of what we call myosin modulators. Okay. It does, doesn't it? Yeah. It really does. We were sort of talking about this beforehand. When I show this, it's like hypnotizing the audience. It's amazing. So this is what you're seeing here is that contractile apparatus of the heart. You get this protein here, which is beta-myosin, which binds to this protein called actin. And there are millions and millions of these little things inside your heart which are making the heart cells do this. Now, by understanding the biology of this disease, what we know is that some of the genetic mutations that cause hypertrophic cardiomyopathy make this protein hang on for too long to this filament here. And that generates signals which makes the heart thicken. And so it was argued, well, if we can maybe inhibit this a little bit, maybe we can reduce this signal for thickening of the heart. And then after a long time, a lot of experiments, a lot of work, a drug was invented called mavacamten, which does exactly that. And now we have a randomized trial in hypertrophic cardiomyopathy. I can't believe I'm saying that, because it's a pretty rare thing. Giving patients in the Explorer trial with obstruction this drug or placebo, and what happens? You feel better, you can do more, the obstruction reduces, and markers in the blood, hormone called BMP, another hormone called protein called troponin, reduce, saying that the heart is under less stress. It makes people feel better and function better. This is, if you take this end of the scale here, this is looking at a score which determines how well you function in daily life. And there was those who reported significant improvements, much, much greater with the drug. And another interesting study, the VALOR trial, which showed that if you were listed for surgery for your outflow tract obstruction, then in this highly selected group, you could take 80% of those people who'd been listed and get their symptoms down to the point where they no longer needed an operation. So we've gone from beta blockers, diazepam, calcium antagonists, which I've been talking about for so long it bores me senseless, if I'm honest with you, because it hasn't changed in 30 years, to suddenly a new way of treating obstruction. Now, my surgical colleagues are a bit worried. Are you going to put us out of business? Because many of you in the room I know have had this operation already. This is what you do when the drugs don't work. So it's open heart surgery, you go on bypass. The surgeon has to look down through the main blood vessel which comes out of the heart, the aorta, and then through that he puts his knife and chops out a bit of muscle, like so, and opens up the outflow. And this is a very effective operation if you select people properly for it and you have a surgical team with expertise. But they're not going to be put out of business. Because whilst this drug is a significant step forwards, it's not a panacea. Not everybody responds to it. And the experience in the States where the drug was licensed before the UK, it is now licensed in the UK, was that you initially saw a drop-off in referral surgery and then they've taken off again. Because suddenly there's a huge new focus on the management of outflow tract obstruction, and being okay is no longer acceptable. Is there innovation in surgery? The surgeons are always tinkering around with this operation. Something which, I don't know, it often brings out rather unfortunate responses to people. This is a technique which has been pioneered at Fuwai Hospital in China, where the scale of stuff is just totally different. They do 500 of these a year. This is not done on bypass, this is done on a beating heart. And what you do is you insert this device from the tip of the ventricle of the heart, and it's got like this little device which slices off a bit from the septum. It's an example of where even surgery may be evolving to be much less traumatic to individuals who actually do need an operation. So obstruction, there's a lot happening. What about this problem of heart failure, and particularly in hypertrophic cardiomyopathy? Well, as I say, the problem here is that these grey bars shows you, if you look at the bad things that happen to people, we haven't had an impact on heart failure at all. In hypertrophic cardiomyopathy, we give the usual drugs that we give to dilated cardiomyopathy, which, as I've shown you, is very effective, but in hypertrophic cardiomyopathy, it may help symptoms, but there's not much evidence that it improves outcomes. Our friends, the myosin inhibitors, may have a role here. So whilst the way these drugs work, as I've said, is they sort of inhibit this contraction of the heart a bit, but they also do something else which is very interesting, which is they help the heart to relax. And we don't really have drugs that do that very well. So they can make the heart less stiff. And that's what part of the reason why people with hypertrophic cardiomyopathy and restrictive cardiomyopathy get symptoms, because their heart is stiff. So now there are trials in non-obstructive hypertrophic cardiomyopathy using this drug as another drug called aficamten. There's a hint in reductions of biomarkers in the blood that it may be effective. We'll know next year whether it's effective in non-obstructive disease. And again, just to make this point, this is from one of the companies making a drug called aficamten. This is their current pipeline and trials. They and other companies really think there's an opportunity here. The final bit, nucleic acid therapies, what does that mean? Nucleic acid, so that's the stuff that makes up your DNA, your genetic code. Now, if we're dealing with genetic disease, wouldn't it be great if we could correct or compensate for the consequences of a genetic mutation? And there are different ways of doing that, in theory. One is that some genetic mutations stop a particular protein being made. So perhaps we could get a copy of the normal gene into those cells and raise the level of protein again. This is gene replacement. Another way is that some of these genes, you get a protein that's made, but it's toxic. So if we could silence that gene, stop the toxic protein being produced, again, maybe that can result in improvement. That's called gene silencing. And then the real space-agey stuff is to say, okay, we've got this spelling mistake in the gene. Can we chop it out and repair it? And that's gene editing. All of these things are now happening. So in terms of gene replacement, the challenge of gene replacement is how do you get the normal gene into the heart cells? Do you have to inject it? Well, the current way that's being examined is using a vehicle, a carrier. In this case, it's a benign virus called an adenovirus. And you stick the genetic material inside it, and then you inject the virus, it circulates around and is taken up by the heart, and it releases the gene. I say the viruses are denatured, and this is being used in a number of different areas of medicine, and the first patient with hypertrophic cardiomyopathy has now been dosed using this technique in the States. And we hope that the first one will be dosed in the UK next year. Where's the trials team? Hello? Where are you? Should you come? There you are. Next year, right? So we'll see what this does. It's not easy. Getting stuff into the heart is damn difficult. Another problem, although it's a benign virus, it can still trigger the immune system, so you have to give it with immunosuppression. Unfortunately, these viruses are out there in the environment, so if you've been exposed to them, you may have antibodies, and at the moment, if you have antibodies, you wouldn't be a candidate for this therapy. How long does it last if you can get these bits of normal gene into cells? Does that last forever, or does it wane? But I put this one on, for me the challenge here is knowing what it's actually capable of doing, because that will affect how we design trials. Could this be a cure? Or is it just going to make the chest pain better by 5%? Because if it's the latter, it probably won't make it into prime time. If it completely changes the heart, that's a major step forwards. But at the moment, we don't know. It's going to be a very exciting ride, that one. We don't necessarily need to start sticking viruses carrying genes to the heart. This is the silencing approach. This is our old friend amyloidosis. There are little bits of nuclear material, RNA, that we can inject, which silence genes and can turn off bad genes. In this case, this is amyloidosis again. It turns off the gene making that protein. And then the science fiction stuff, can we fix the underlying genetic code problem? Well, here's a way of doing that. So what you're seeing here is something that's found in bacteria-like organisms called archaea. They're not relevant to human disease. But what they do have is an immune system of their own in a way. Within these single-cell organisms, they have this structure, which is called Cas9, which is an enzyme which has inside it a little library of DNA which has been generated by exposure to previous viruses. And if the virus comes back, this enzyme goes onto that virus, binds onto it with this little template it has, and then it basically chops up the viral DNA. Understanding this mechanism led to a Nobel Prize, because you can use this mechanism in experimental models to create new genetic models in a lab. But what if you could get that enzyme complex into a cell targeted to a specific genetic mutation causing cardiomyopathy, chop it out and put a new one in? So it has been done. Amyloid, get a little package, get that enzyme, send it to the liver, turn off the gene. If any of you were following the news yesterday, a cure for sickle cell anemia using that technology, basically correcting the underlying genetic defect that's causing sickle cell disease, so you're curing sickle cell anemia. Can we do that in cardiomyopathy? Who knows? So, I come to that, to my, I don't know why I've got a Sherlock Holmes slide there, I just thought I might. But this conversation wasn't possible 5 years ago. And I don't know whether all of this stuff's going to work. But even if only 10% of it works, or 30% of it works, that's a massive step forwards, moving from what is essentially palliation, treating the consequences of disease, and now actually starting to dream about cure, and maybe even prevention. Because if you think through the logic of this, if you can identify people who are carrying genetic variants, maybe you could fix that before they ever go on to develop cardiomyopathy in the first place. Welcome to the future. Thank you very much.